Okay, Assalamu alaikum. This is a case with our master student, and he came to do an anterior bridge. Okay, does he want to make it as a connected bridge or separate bridges?
Connected.
Do you want to, you're going to include this incisor or not?
Maybe we're going to do a cantilever.
Yes, it's better to be separated from the centrals. Okay, so it's cantilever. Suppose I want the same shade of the teeth. What do I do?
I would
Because
say
selecting or the aesthetics of anterior zone is very critical. How am I going to do that with the teeth, anterior teeth not connected into the bridge? What another option do I have?
another option for the shade.
Yes, because I want to unify all of the anterior teeth into one shade.
Yes, I will take each third. I will take like the shade of each third. To make
Okay,
it
yeah, shade matching, but it's too complicated as shade matching. Can you do something simpler? What if you do veneers on the anterior?
yeah.
You can do them as veneers. So this will solve the problem of aesthetics without the need to connect the central to the posterior bridge.
Yes.
Okay.
And,
But they
more
should be
conservative.
separated. Why is it critical in this location exactly, and exactly this case? Why is it so critical to disconnect the posterior bridge from the anterior teeth?
To disconnect.
Not have them in a large span bridge with multiple pontics,
Maybe
multiple pontics and multiple
Because I think
abutments.
the peer abutment, the prognosis of the peer
First of all,
abutment.
it's a peer abutment.
Yes.
This by itself is a risk.
There is a fulcrum.
Okay. There's another reason. What is the direction of the
Direction
movement of
of-
the
yeah.
fremitus? Which is the
Direction.
movement of the tooth in the socket.
Different.
Yes. The
Central
anterior
lateral.
teeth move towards the front.
Yes.
The canine moves towards the diagonal.
Yeah.
And then the premolar moves to the buccal.
Yes.
So you have different locations.
Too much force is different.
It's the direction of the forces actually. It will destabilize this bridge on the long term or produce cement layer interruption. Okay. So what is the option? As you said, a posterior bridge with an anterior cantilever for the
Lateral.
the premolar is the main pontic,
Yes.
and the lateral is a cantilever pontic. Okay. Where was the recent extraction? This was another reason why I'm filming this video.
Yes.
Where was the recent extraction?
This one.
The 4?
Yeah.
Okay, it seems that they had a fracture of the buccal plate as well. Okay,
It was
so
a
we'll have.
traumatic extraction.
It was a traumatic extraction. And what about the extraction of the lateral? It's also recent,
Yes, it's more than 1 month.
more than 1 month. Okay,
But it's
what do you have an option for this? What options do you have?
we can start preparing for the long-term temporization. Like
Yes,
you said.
long-term temporization is a benefit here, where you can shape the gingiva, especially if you place a connective to graft here. You shape the pontic area, which is the ridge, the edentulous ridge, with a graft, and you can use the long-term temporization to shape that gingiva into the shape as if the pontic is growing from outside, as if it's a marginal gingiva.
Like the implants when we put the gingival
Former.
former.
Yes, so it's a gingival former. So you design the gingival side of the pontic in a way where it shapes
Heals
the
over the
yes,
temporary.
the tissue. But do you have enough tissue? Do you have enough attached gingiva? Move the gingiva. Look at them attached gingiva. It's very close to the extraction socket.
Yes.
صح? We have
Yeah.
lost the attached gingiva here. Okay, so this will be traumatic to the tissue beneath the pontic. So we have to do a graft here, either a bone and tissue or a thick connective tissue graft will serve us and give us the attached gingiva we need. And because it will be, you can shape it because it's freshly extracted from its location and then put here the donation location and then placed here the graft itself. You can shape it into a hollow in the middle as if there is a socket, and you place the long-term temporization where the pontic has a dome shape, and it shapes the gingiva in the same form that you want your pontic later on to come and touch the gingiva in it. Okay?
Yeah, yeah.
So this is a good chance for healing tissue to accept a graft and be shaped into more aesthetic.
More aesthetic, yes.
Okay?
It will look more natural.
The only problem here is having no attached gingiva beneath the tooth. So you need to stabilize the graft in another way. You could do some attachment. You can do some bone graft with it, combined, or tissue attachment. But you need to use a graft that produces attached gingiva as a main function or a main goal for you for the grafting. So it's not only the aesthetics, it's the attached gingiva that we need to restore here.
Yes.
Okay?
If we didn't restore the gingiva,
What
it
will
will not
happen?
heal over the. We won't have enough
Okay.
tissue over the.
Yes, that's
Okay.
one. Secondly, you need to wait until the socket is totally is
Totally
clear,
healed,
totally, or let's say the resorption has stabilized. We know the resorption continues
Yes.
lifelong, but the most stable is after 6 months. So you have to wait for that whole period, waiting for that to heal.
Yes.
And then once it heals, because if there is a defect and then attachment loss, most probably you will need to add a pontic with gingival porcelain, because you need to replace the bone as well. Okay.
Yes.
So all of this are different treatment options with grafts, without graft, waiting for it to heal. But anyways, you do need long-term temporization. What material will you use? Will you use shear side composite? Shear side, direct temporization? No. It's preferred here to go to the lab indirect material, temporization material, because it's more long-term.
Yeah.
I want long-term temporization, okay?
Okay.
So it's just changing the material and changing the technique. It will be indirect. It's preferable for long-term temporization to have it indirectly done in the lab with material that's stronger than the acrytemp that we have here. Okay?
And it has to be out of lateral exclusion.
Excursions, yes, with minimal. Okay, let's say if you need to want a long-term temporization, you will see the group function. You have to have group function on the site and lateral excursion with minimal occlusal contacts on excursions. Yes,
On pontics.
on the pontic. Yes. The canine is reduced in size. صح? Yes.
Yes.
It's not the best
Yeah.
preparation.
That's why
But
I
this is
thought
the
that,
older preparation.
If we attach the centrals with this bridge, it will the bridge will compromise also the central, because the peer abutment has a poor prognosis.
Yes, but still, it's not the main reason. The main reason here is the location in the arch.
Yeah.
Because you're on the
Direction of the
corner.
forces.
Yes, direction of forces is also a bigger problem, other than being a peer abutment. So and each one is a big issue, and those are two joined in a poorly prepared canine.
Yeah.
Okay, so the frill effect here is reduced. Has there been any treatment, endodontic treatment to the canine?
Yes, it is indicated.
It is endotreated.
Yes,
Wow.
it needs
Another
limiting
limiting feature in the canine. So this will we can place a bridge, but it will be of limited prognosis. The time limit will be short for it. It's preferable to place an implant. If the patient can afford a bridge, a conventional bridge, but as a temporary case until the canine is resolved, or because this is a post and course, huh?
Yeah.
And the frill, how much frill do you have? Very minimal frill.
Yeah.
صح? So all of these are coming all together. But what if we make a bridge, posterior bridge with an anterior cantilever? On this poor prognosis, we can perform it, but we have to tell the patient we will choose the material that he can afford, and this might need we need to guard the prognosis, meaning we have to do multiple recalls and like every couple of years to check on the longevity of the bridge. And once anything happens, and it is expected, we're going to change either to a partial, removable, take an implant, or whatever. Okay. So it's compromised for 3 points now. The quality of the tooth itself, the canine as well. Okay? Okay, thank you for the nice case and the nice discussion. Thank you, Doctor.